Okay, there's still a question on the screen. That's the newer insulin analog, is that? We need to, okay, okay, so ladies and gentlemen, dear colleagues, first of all, thank you very much for giving me the opportunity to give this talk. This is a very special time here in Finland, I can tell you. We are celebrating the midsummer, and this is unique. I'm actually giving a talk during the midsummer. You know, even if the ADA would be, if that would be during the midsummer, no Scandinavians would ever attend the ADA. It's just, midsummer is just like Christmas. So, but it's interesting. This is very interesting, but I'll do it now. So, so the talk of today will be cardiorenal benefits of SGLT2 inhibitors. These are my disclosures, so what I will talk about first, a few words on the consequence of diabetes. After that, a few words on the SGLT2 inhibitors and cardiovascular outcomes. After that, I will talk about dedicated randomized controlled trials with SGLT2 inhibitors in heart failure. A few words on prevalence and consequence of diabetic kidney disease, then SGLT2 inhibitors and renal outcomes, and then dedicated RTCs with SGLT2 inhibitors and DKD. And finally, we'll ask the question, why do the SGLT2 inhibitors work so well? So first, the consequences of diabetes. If you look at the consequence of diabetes, this is an important slide because it tells us if you have a 60-year-old individual, you can see that without diabetes, there is a certain life expectancy that people still live on. But if you have diabetes, you can see that that life expectancy is shortened by 6 years. If a patient with type 2 diabetes have suffered a myocardial infarction, that life expectancy is shortened by around 12 years. So diabetes, and especially if you have diabetes and cardiovascular disease, come with grim consequences. However, later on, I will show you another picture which tells you another story about this, which is even worse. But keep that in mind, diabetes plus established cardiovascular disease is actually coming with grim consequences. And the reason is that you can see from this slide that, yes, it is cardiovascular disease that makes the life expectancy reduced, stroke, myocardial infarction. And if a patient will have both suffered a stroke and myocardial infarction, the hazard ratio is very, very high. And of course, one of the big problems in type 2 diabetes, and also in type 1 with kidney disease, but especially in type 2 diabetes, that comes with heart failure. And you can see the red lines are those with diabetes, and the blue lines, no diabetes. And you can see that HFrEF, reduced ejection fraction, comes with the worst prognosis. And that is, of course, natural, because if you have reduced ejection fraction, it means that you have damage to the heart. But you can also have problems with the heart failure, because of diabetes, inflammatory changes, stiffening of the heart, and that is usually giving, clinically giving the sign of preserved ejection fraction and diastolic dysfunction. But heart failure is something that is very important and very common in patients with type 2 diabetes. So diabetes comes with a shortened life expectancy. You will have an increased risk of cardiovascular disease and also of heart failure. So what did we learn from the cardiovascular outcome trials with SGLT2 inhibitors? And here I will only talk about the EMPA-REG, because EMPA-REG was the first one, and then I will sum up with the others. But let me show you the results from the EMPA-REG. Data that were made public, the EASD in Stockholm back in September 2015. So EMPA-REG outcome trial was a trial in people with type 2 diabetes and established cardiovascular disease. You can see that more on the left-hand side, about 7,000 patients, and they all had established cardiovascular disease. And this is important and slightly different from the two other similar trials, the Canvas program and the Declare TV. And you can see here, people were allocated to placebo or empagliflozin 10 or 25 milligram. And the primary endpoint was a 3-point MACE, excuse me, which basically means cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. But you also had other pre-specified outcomes, and I will show you also the data from this. These were pre-specified, not the primary outcome. So this slide summarizes the data. So you can see a 14% reduction in the 3-point MACE, and this was a revolutionary result, because before that we had not seen that any, by definition, glucose-lowering medication will reduce a cardiovascular disease, as shown here by a 14% reduction in 3-point MACE. And this was very much driven by the reduction in cardiovascular death. You can see 38% reduction, which is very nicely shown in this slide too. But what is particularly important from this slide is to see that the effect of empagliflozin, either 10 or 25 milligram, they had a similar effect. So all the data are pooled for both doses. And you can see that the effect on the cardiovascular death was an early finding, and it was sustained throughout the trial. So that was a remarkable result. And also when you look at one of the pre-specified outcomes, which was hospitalization for heart failure, here you can see again a very immediate effect on a reduced risk of hospitalization for heart failure and sustained throughout the trial. And also all-cause mortality was significantly reduced by 32%. So these results were absolutely remarkable. But people are a little bit curious to see, is this just by chance, or could this also be shown with other medications of the same class? So let me now show you, in summary, also the Canvas program data and the Declare TIMI in comparison with the EMPERIC outcome trial in terms of the 3-point MACE. And you can see that the Canvas program also showed a 14% reduction in the 3-point MACE. So very similar data compared to the EMPERIC outcome trial. But the Declare TIMI did not show a significant effect. Now we have to keep in mind that the Declare TIMI included about 10,000 patients with risk factors for cardiovascular disease and 7,000 with established cardiovascular disease. It was a different population. Now, if you look at this slide here, if you do a meta-analysis, you can see that, yes, this is significantly lower. Now, let me remind you, when they asked the question, that the polling question here, the question is, can we explain a non-significant result by a meta-analysis significant result? My view on that is no, you cannot do that. But what we can say is that, yes, the class, they seem to go in the right direction, but the molecules seem to be slightly different. Let me now then look at the cardiovascular death when you stratify for those with established cardiovascular disease, because the EMPERIC outcome trial, that was all established cardiovascular disease. The Canvas program also included some patients with risk factors, and the Declare team, as I said, 10,000 risk factors, 7,000 established cardiovascular disease. You can see that the only molecule here that showed a reduction in cardiovascular death was the EMPERIC outcome trial. And this is also now seen in, for instance, the ESC guidelines. They highlight this finding. Now, down here, it's interesting to see that if you look at those with multiple risk factors, because there were people with multiple risk factors in the Canvas and Declare, no effect on cardiovascular death. This is very interesting, and I will show you other slides later on that give very interesting data. If you then look at the hospitalization for heart failure, all three trials show a reduction in the risk of hospitalization for heart failure. You can see down by 31%. Very consistent findings. Now, all these cardiovascular outcome trials, and especially the data on heart failure, that was astonishingly good results, but they were not the primary outcome. So the question is if you do a dedicated trial in patients with heart failure, can you show that data? And fortunately, we already have the data from one such trial, and that is the DAPA-HF. The primary composite endpoint to the DAPA-HF was worsening heart failure or cardiovascular death. So it was a composite endpoint. Now, interesting, in the DAPA-HF, half of the patients had one part of the patient had diabetes and the other did not have diabetes. So here they looked at the effects of dapagliflozin on heart failure in both diabetics and non-diabetic patients. And you can see a 26% reduction in the risk of ending up in dialysis, in hospital because of heart failure or experiencing a cardiovascular death. And that 26% was very much driven by heart failure. Here you can see this is the effect on the cardiovascular death, 18% down, but here you can see that 30% down for the hospitalization for heart failure. So it seems that the SGLT2 inhibitors have very strong effects on the heart failure. And now I will switch to kidney disease, because it's also very important to keep in mind that people with kidney disease, they very often also develop heart failure. But the good news is here that the data from the EMPIRIC outcome trial, that was the first out, have been replicated in other trials. And also now we have a dedicated trial in heart failure showing that SGLT2 inhibitors have positive effects on the risk of ending up in hospital because of heart failure. Let me now switch gears totally and look at kidney disease. So the prevalence and the consequences of diabetic kidney disease. This is a very busy slide, shows in the middle here the DEMAND trial. That was a trial when Henrik was looking at what is the prevalence of diabetic kidney disease around the world. And this trial included more than 27,000 patients with type 2 diabetes. And they were at random tested for the albuminuria, so an albumin creatinine ratio above 30, or a reduced eGFR, or both. And what you can see here, that when you go out and test for the presence of kidney disease, 56% on a global scale had signs of diabetic kidney disease. And you can also see that if you go to Asia, it's 68%, Central America, South America, 61%. So this means that diabetic kidney disease is common. Then the question is, why is it then important to find out whether people have diabetic kidney disease? Yes, because the consequences are grim. And just let me show you here from the DEMAND trial. You can see that, of course, albuminuria is the most common sign. Also, a reduced eGFR is in about 22%. And then some of them have both. So these are all measures of diabetic kidney disease, but they don't give you the same information. So albuminuria is probably a sign of the integrity of the podocytes in the kidneys, while a reduced eGFR is more fibrotic changes in the kidneys. But if you have any of these signs, it actually means diabetic kidney disease. And that means also that these patients with diabetic kidney disease, they will have an increased risk of premature death. Here you can see that in comparison with no kidney disease, if you have albuminuria or a reduced eGFR or both, you have a manifold increased risk of dying early. So very, very important. You can see here in the middle here, increase in 10-year mortality, so 11 times higher in patients with type 2 diabetes with albuminuria, reduced eGFR, than in those without. So diabetic kidney disease comes with an increased risk of premature mortality, but also with an increased risk of cardiovascular events. So the less the kidneys function and the more albumin that leaks into the urine, the more likely the patients are to face a cardiovascular event. And this slide shows again what I was alluding to a few minutes ago, that left-hand side, we have the eGFR. So when you lose kidney function, you will have an increased risk of ending up in hospital because of heart failure. When you increase your albumin excretion rate in the urine, you can see that, yes, that is also associated with increased risk of heart failure and hospitalization for heart failure. So diabetic kidney disease comes with grim consequences. And of course, it also comes with an increased risk of ending up on dialysis. I promised to you in the beginning, I'm going to show you a similar slide as I started with. I said that diabetes by itself, a 60-year-old patient with type 2 diabetes, you can expect a 6 years shorter life expectancy. If the patient will have suffered a myocardial infarction or a stroke, that comes with a 12 years shorter life expectancy. But look at this. A type 2 diabetic patient, 6-year-old, if you find signs of early diabetic kidney disease, that means albuminuria, reduced eGFR, or both, you can expect a 16 times shorter life expectancy. So diabetic kidney disease comes with grim consequences. Now, what have been learned from the cardiovascular outcome trials with SGLT2 inhibitors? So on the renal outcome. Now, let me point out that these are all secondary outcomes. So they need to be tested, replicated in dedicated trials. But what did we learn from the cardiovascular outcome trials? So the EMPA-REG outcome trial showed a 39% reduction in new onset or worsening of diabetic kidney disease, which was a remarkable result. So not only effects on the cardiovascular side, but also on the kidneys. If you look at doubling of serum creatinine, initiation of renal replacement therapy, that means dialysis or transplantation, or death due to renal disease. By the way, any of these trials, they all include this death due to renal disease, but that basically means that the patient should have been on dialysis but refused. And in all these trials, it's between 2 and 5 patients. So the majority is initiation of dialysis or doubling or serum creatinine. And doubling or serum creatinine means 57% reduction in eGFR, not 50. So 57. So this is a very, very hard endpoint. And you can see that in the EMPA-REG outcome trial, there was a 46% reduction in the renal endpoint. Wonderful result. And in the EMPA-REG, what was shown, there was an initial drop in eGFR, after which you could see a preservation of the kidney function. And this is something that we have been waiting for a long, long time. After the ACE inhibitors, angiotensin receptor blockers, now with the SGLT2 inhibitors, we could see a similar result. Wonderful, a way to preserve the kidney function. Now, these data from the EMPA-REG outcome trial were then replicated in the CANVAS program. You can see here in the CANVAS program, a 40% reduction with canagliflozin in the composite endpoint or renal endpoint. But here you can see they used a 40% reduction in eGFR instead of a 57%, so doubling on serum creatinine in the EMPA-REG outcome trial. But you can see similar data as in the EMPA-REG. So now we had 2 trials with secondary outcomes showing renal benefits. And again, initial drop in the eGFR and preservation of the kidney function. So 2 trials, similar results. And then the third, DECLARE. If you then look at the renal composite endpoint and cardiovascular death, they combine those, you can see that, yes, it was a reduced risk of renal composite endpoint and cardiovascular death in with the dapagliflozin. Now, this slide is very interesting because if you think about what I told you a minute ago when I said that the effects on cardiovascular disease in those with atherosclerotic cardiovascular disease seems to be there. And here you can see when you look at the composite renal worsening and disease, so renal death by the presence of established atherosclerotic cardiovascular disease, you can see that absolutely wonderful effect, 44% reduction. But now, if you look at those with multiple risk factors, for the cardiovascular outcomes, there were no effects. But on the renal side, yeah, we can see effects. So this means that basically, based on these cardiovascular trials and secondary outcomes, it seems that the effects on the kidneys are even stronger than on the heart. We can come back to that later. But again, these were secondary outcomes, so we need to replicate in these findings in dedicated trials. We are fortunate enough to have such trials. One is already reported, and we have 2 more ongoing. So the Credence was the first to be reported. Here you can see the a composite endpoint of end-stage kidney disease, doubling of serum creatinine, again, 57% reduction in eGFR, renal or cardiovascular death. So this was a combined composite endpoint of a renal and cardiovascular death. And you can see down by 30%. Interestingly enough, if you look at only the renal part, an even stronger effect. So if you get rid of the cardiovascular death, the effect on the kidneys seemed to be even stronger. And it was very interesting because when you look at the data from the Credence trial, you can see that the average Credence patient was a 63-year-old patient with type 2 diabetes and baseline eGFR of 56%. And what happened? If you think about that, below 10 ml per minute, basically the patients are already on dialysis. So here you can see that this is what happened in the placebo group. The placebo patients lost 4.6 ml per minute per year. But the ones that was exposed to canagliflozin, you can see that much less, so 1.9 ml per year. And if you calculate the years, you can see that basically by exposing the patients to an SGLT2 inhibitor, you could win 15 years. And you remember what I told you, immediately when you see signs, early signs of diabetic kidney disease, you basically can expect a 16 years shorter life expectancy. These are data that are, of course, extrapolated. This has not been tested yet, but the potential of being able to prevent the progression and improve the prognosis of our patients, it seems to be there, and it looks good. The Credence on the left-hand side here, Credence trial included only patients with type 2 diabetes, and they had to have albuminuria, as seen here. Now, the DAPA-CKD also includes patients without diabetes, so type 2 diabetes or non-diabetes. But these patients also have to have albuminuria. Now, you can see that in the DAPA-CKD, the eGFR goes down to 25, while it went down to 30, so between 30 and 90 in the Credence. Now, in the EMPA-KIDNEY also contains non-diabetic patients, but also not only type 2, but also type 1. And here you can see that if the patients had an eGFR below 20 and 45, so in the EMPA-KIDNEY, we go down to 20. So between 20 and 45, the patient didn't even have to have albuminuria. But if they were between 45 and 90, they have to have albuminuria. This is important because there are a lot of people, about 20% of people with type 2 diabetes, that will never ever develop albuminuria. And these guys still have diabetic kidney disease, probably due to aging, hypertension, and obesity, but they still have diabetic kidney disease. So this will now also be tested in the EMPA-KIDNEY and also the DAPA-CKD non-diabetic kidney disease, as also in the EMPA-KIDNEY. So exciting results coming up, but we already have the wonderful data from the Credence. So finally, let me just give you some ideas. Why do these SGLT2 inhibitors work so well? This very busy slide on the left-hand side, during a euglycemic clamp, but here we have a hyperglycemic clamp. So these patients are all type 1 diabetic patients. Now, we have to keep in mind that this was done in patients with type 1 diabetes in order to be able to study real hyperfiltration, because patients with type 2 diabetes, it's very difficult to say that they are hyperfiltering. We assume that they are already, although the eGFR is low. So in patients with type 1 diabetes, they're hyperfiltering. If you expose them to 25 milligram empagliflozin, you could see a reduction in the hyperfiltration. If the patients had normal filtration, nothing happens. And that was exactly the same during euglycemia and during hyperglycemia. And anytime, so this slide shows clearly, if you have hyperfiltering patient, you will also see an increase in the intraglomerular pressure. So you have glomerular hypertension. So if you then give empagliflozin, 25 milligram, to a normal filtering patient, nothing happens. But if you give it to hyperfiltering, you reduce that hyperfiltration, and you actually also reduce the intraglomerular pressure, which means that you actually spare the kidneys from further damage. And this is associated also with a decrease in the renal blood flow and also an increase in the renal vascular resistance. And when you see a decrease in renal blood flow, an increase in renal vascular resistance, that basically means that you have an increased tone of the afferent arteriole. And this busy slide shows that on the left-hand side, the normal physiology. You can see these SGLT2, these co-transporters in the proximal tubule. The reason why we have these is that during the evolution, we need to harvest glucose because glucose is a substrate that we need. It's energy. So we need to get hold on that. But also it's important because these transporters also make sure that sodium is reabsorbed, but not all sodium. So some of the sodium needs to reach the macula densa. Macula densa works as a control tower of the glomerulus, just like a control tower of an airport. And you can see that when small amounts of sodium reaches the macula densa, there is another co-transporter consisting of 3 parts, sodium, potassium, and chloride. This one is the same way that the furosemide affects on. So this transporter senses sodium, small amounts are absorbed, and that needs energy, so you go from ATP to ADP, and you generate adenosine, which is a very, very strong vasoconstrictor of the afferent arteriole, working on this afferent arteriole. If you have a situation where you have hyperfiltration, for instance, in diabetic kidney disease, you can see that you have an exaggeration of the reabsorption of sodium and glucose. Sodium is not reaching the macula densa, and you are not generating the adenosine. And instead of having an increased tone of the afferent arteriole, you will have vasodilation. And in the textbooks of diabetes, you will read that patients with diabetes usually have vasodilation of the afferent arteriole. That is not due to diabetic neuropathy, which you sometimes can read in the textbooks. Is actually due to the effect on adenosine. On the right hand side, you have then a situation where you expose the patient to an SGLT2 inhibitor, and you can see sodium reaches the macula densa because you block the exaggerated reabsorption, and then adenosine is produced. So that is the way how these medications work and have so profound effects on the kidneys, and not only on the kidneys, but also on the heart. So, ladies and gentlemen, let me come up with a few take-home messages here. So the first is that diabetic kidney disease is common and closely related to cardiovascular disease with grim consequences. Increased risk of dying early, an increased risk of cardiovascular disease, also an increased risk of ending up on dialysis. And SGLT2 inhibitors provide cardioprotective effects. Also, the renal protective effects of SGLT2 inhibitors seem even stronger than the cardiovascular effects. This, we can discuss that. Credence proved the renal protective effect of SGLT2 inhibitors. So the secondary outcomes, wonderful effects on the secondary outcomes, were actually replicated in the Credence trial. And DAPA-HF proved the effect on HFrEF, so reduced ejection fraction, not only in patients with diabetes, but also in non-diabetes. So, and also finally, I'm happy to say that these observations are already endorsed by the new guidelines. That said, ladies and gentlemen, thank you for your attention, and I'm happy to take questions.